So I'll just to complete the course, I'll just take you through lasers and ultrasound for refractory glaucomas. And refractory glaucomas comprise all forms of glaucoma in which the IOP remains uncontrolled despite maximum tolerated medical therapy and previous laser or surgical procedures. IOP remains uncontrolled also after repeated standard filtration surgeries, and surgical approaches for refractory glaucoma include techniques increasing the aqueous humor outflow, that's filtration procedures or drainage devices, and techniques reducing the aqueous humor inflow by destroying portions of the ciliary body. Now, several cycloablative methods have been proposed over the years, like cryotherapy, microwave heating, endoscopic laser photocoagulation, transscleral diode laser photocoagulation. And given the occurrence of potential vision-threatening complications, unpredictable dose-effect relationships, significant variability in the final IOP lowering, and poor reproducibility, the ciliary body ablation is still considered as a last resort treatment, recommended only in patients with refractory glaucoma. So the high intensity focused ultrasound technology was proposed as a safer alternative of ciliary body destruction in the 80s and 90s by Sonocare. This technique permits a selective thermic effect on the target organ, limits damage to neighboring tissues, and allows treating non-optically transparent structures. Nevertheless, because of the excessive complexity and duration of the treatment, the technique was progressively abandoned despite evidence of good efficacy and safety. In the last 3 to 4 years, this has again been reconsidered after critical clinical modifications and significant improvements in all steps of the procedure. So talking a little bit about cytophotocoagulation, we have the transscleral cytophotocoagulation and we have the endocytophotocoagulation. So cytophotocoagulation actually reduces aqueous production by destruction of the ciliary epithelium, and the techniques are transscleral, transpupillary, and endolaser. Indications I just told you: failure of multiple filtering surgeries and the rest of it. So diode laser transscleral cyclophotocoagulation, method of ciliary ablation with success rates from 40 to 80 and performed with the diode laser, and these are specific with the endoscopic laser cytophotocoagulation performed also with the diode laser, and the actual time of exposure is based on visual effect of ciliary process shrinking and whitening. And we have the cyclodestructive procedure, the continuous wave cytophotocoagulation, that's ab externo and ab interno, and the micropulse cytophotocoagulation. So what we're actually going to talk about is the micropulse, which is being used nowadays. So endocytophotocoagulation, this is for mild to moderate glaucoma done with cataract surgery, relatively low risk, and of course is to be avoided in uveitic eyes. So endoscopic photocoagulation is a cyclodestructive procedure, and it functions to minimize the disadvantages of more traditional cyclodestructive procedures and delivers laser energy to the ciliary body, ablating the ciliary body epithelium to decrease aqueous formation and thereby lower the intraocular pressure. So this is what is being used nowadays, micropulse cytophotocoagulation. It's a gentler form of the cytophotocoagulation, and it appears to work very much like the drop pilocarpine. It has a mechanical effect, and it's a low risk profile, and you actually apply it in a semicircle over the hemisphere, and there are time gaps after each application. So this study actually shows that it uses the slow application of laser energy that is chopped into micropulse or bursts and does not burn or destroy the eye tissue. And the results, as you see out there, 33% IOP reduction at 18 months and 61% reduction in medicines, glaucoma medicines, after doing this treatment. So at a glance, micropulse transscleral cyclophotocoagulation has proven to be safe, effective, and reliable approach for lowering intraocular pressure. Unlike other interventions, delivers energy in a 31.3% duty cycle, allowing tissue to cool between each application. So there is a minimal impact on target tissue and a reduced risk of injury to the adjacent ocular tissue, and can be used early in disease course and requires minimal medication, reducing the reliance on anti-inflammatory drops post-op procedure. It can also be used on a wide range of glaucoma glaucoma cases, depending on the severity, and of course in most advanced cases of disease progression. Then we have the ultrasound cycloplasty. It's a novel device employing high-energy focused ultrasound for the coagulation of the ciliary body with the aim of achieving selective coagulation of the ciliary body while sparing the adjacent structures. The high-intensity focused ultrasound is a non-invasive procedure that delivers highly concentrated sound waves to the ciliary body, reducing aqueous production and increasing the outflow, thereby lowering intraocular pressure. So UCP brings about a reduction in intraocular pressure via multiple mechanisms of action that result in decrease of aqueous humor production by selective destruction of the ciliary body, increase in aqueous humor evacuation by inducing a stimulation of the suprachoroidal and transscleral portions of the uvascleral outflow pathway. And these are videos of we did a small study with it, and that's the machine that you see out there. And this is the docking instrument, the cup with which you have to create vacuum. The green line that you see out here is when your instrument is ready to start firing the ultrasound waves. And once you do on one hemisphere, you got to turn it around and you can do on the other hemisphere. And you can actually choose your time interval, and there's a gap of 20 seconds between each. So I've chosen, say, these two, and the ultrasound will be delivered to that particular area. And that's 20 seconds. And then again, there's a 20-second gap time after it goes and delivers ultrasound to the other area. So that is the time that it shows. And so that's the ultrasound being delivered that you can see, those red Wi-Fi-like lines. And then once the procedure is done, this turns red. And then again, there's a gap of 20 seconds and it will go on to the next one. So that is how it is done. Results of therapeutic ultrasound that's our study over for refractory glaucoma over 1 year. 38 eyes were treated with a mean follow-up of about 18 months. The mean fall in intraocular pressure was 38.6%. Analysis of 3 success criteria. Success varied between 74 to 78 at the mean follow-up time, and complications occurred, mainly inflammation and conjunctival congestion in 8.4%, including thysis bulbi in 0.6 and persistent hypotony in 1.5. There was no mean visual loss. And therapeutic ultrasound appears to be safe and effective for treatment of refractory glaucoma. This is just to show that the energy concentration is over a smaller area than TSCPC. And so these are the literature searches that I did. And they also said that both of them are safe and effective methods for the treatment of refractory glaucomas. Nevertheless, the pain is less severe with UCP. And this study also says almost the same thing, though they say the reduction in intraocular pressure is better with the cyclodiode treatment, but then the complications are less with the ultrasound treatment. So based on cumulative evidence on safety and efficacy, the range of indications for cyclodiode procedures may be expanded so that the patients with less severe disease and better overall prognosis are treated with such modalities. The role of cyclodestruction in glaucoma management will most likely continue to evolve because of the introduction of novel technologies such as the endoscopic diode cytophotocoagulation, circular high-frequency cytophotocoagulation, and micro-pulse transscleral diode photocoagulation. So early evidence with these recently introduced technologies suggests that they have a clinically acceptable efficacy and favorable safety profile. So confirmation of this requires more studies, larger studies, so that we can actually adopt them in clinical practice. Thank you for your attention.